I'm Merceline Dahl-Regis. I'm the Chief Medical Officer in the Bahamas. And we've made significant progress with the management of vertical transmission from mother to child. However, we have many challenges. We'd very much like to have zero vertical transmission. And we think we can achieve that together with congenital syphilis. And we've had a number of meetings to discuss the strategy. And we feel that the strategy that we currently use need to be revisited in terms of greater involvement of males. Many women during the pregnancy, before and after the pregnancy, are reinfected. And to that end, I think we need a specified male program, not only to treat the males, but also to share with them the information that can lead to some behavior changes. They are not readily accepting the use of condoms during pregnancy, and of course, not during the reproductive cycle. That's why the women become pregnant. And if we can impart information that condoms are useful with prevention of reinfections during the pregnancy period, I think it would be a step in the right direction. We know that with any strategy or any message, health message, is easier to begin and more productive to begin at early ages. And we wait until these behaviors are entrenched in sexual practices and then try to interrupt the behavior. Whereas if we started promoting condom use for early sexual initiations, etc., and we run into, that would be useful. In the Caribbean, the religious community is promoting abstinence. The practice is not one of abstinence. And so the messages that go out do not share information about condom use, do not promote condom use. So to change, we all know that if it's not introduced early enough and the benefits are not sold to the public, that later on, after the sexual experiences that they have, they think that condoms impede that. So I think it's messaging, I think it's effective communication, and attention to behavior change communication at an earlier ages. Both men and women, by the way. The strategy for prevention of mother-to-child transmission must incorporate adherence to antiretrovirals. We know that we've had to dot mothers because the medicines make them feel ill. We know that they are not in the best nutritional health, so we have to provide supplemental nutrition. We know there are many other social events that impact the mothers taking the medicines, and we lose a lot of mothers to follow up. So we have to embark on a strategy that encompasses effective contact tracing, not only for the administration of the treatments, not only for the identification of the partners, but also contact tracing in terms of looking at where they are, follow them up, have them deliver in hospitals, and to evaluate the offspring, and to continue follow-up. So this strategy with PMTCT would be better administered if we linked it to the immunization schedules of children, because you have an infrastructure there. If we link it to the social communications that we used with the elimination strategy for congenital rubella, it could be linked also to just maternal and child health services. The baby has to be born, and the earlier we take the approach that this program encompasses a period from conception, preconception for women, as soon as the reproductive period. I'm for men, and the period for the woman is shorter if you go to the reproductive, whereas the men, if you were to really identify a target population, you would target women up to probably 45. The men, you need to target up to 80 or 65, at least 65. So I'm asking the organization to really revisit the strategy, the components of the strategy, and to design an implementation program that is all-encompassing. Mm-hmm.